Giovanna Zorzi will be talking about clinical aspects of PKAN. Welcome, Giovanna.
Hello. Hi, everybody. Good afternoon or good evening, depending on where you are. I'm going to share my screen.
Are you having any problems, Dr. Giovanna?
I just don't know how to share my screen, but I think I'm gonna find. Okay, I have it. Okay, can you see it?
It's almost there. There we go.
Okay.
Yeah, go back to beginning.
And put in presentation. Okay.
Yes, ma'am. And then also,
Sorry.
if you can tilt down the camera just a little bit.
Okay.
Wonderful.
Okay. So the aim of my brief talk is to give you an overview about PKAN and the clinical aspects. So we heard a lot about the metabolic and genetic, about this neurodegenerative disorder. So I will not get in detail, but just please note that PKAN is in the same metabolic pathway as PKAN, but we will see that actually is quite a different disorder. The first two patients were described actually in two Italian patients in 2014, but since then very few other cases has been reported, because if we include the first two Italian patients, there are now only 9 patients that have been described in the literature. And by reviewing the clinical phenotype and the radiological features of all these reported patients, I have identified 3 different phenotypes of the disease. I'm aware that the number is very small, but still it looked to me that there are 3 homogeneous phenotypes that are quite different between the other. So the first is called the NBIA, or Italian phenotype, because it's what we are seeing in the 3 reported patients. So actually these patients are a little bit like PKAN, but with some difference. So after a normal psychomotor development, they all had the onset of the disease around the age 2 with walking disturbances. They all show a progressive spastic dystonia with Parkinsonian features. They all have a cognitive impairment, which actually is quite severe in one of them. And they all developed psychiatric features during the course of the disease. The disease was progressive, but slower than what it is observed in PKAN. There is no impairment of the visual system, in particular, there is no retinopathy. All have a motor axonal neuropathy. And if we go to the magnetic resonance imaging, 2 of the 3 patients have a similar pictures like in PKAN, which means that you see the iron deposition in pallidum, substantia nigra, with the aspect of the eye of the tiger sign. But the third patient have a different phenotype. So first, it shows involvement of caudate and putamen in the sense of hyperintensity, and later on, it developed iron accumulation in pallido and in the basal ganglia. In these patients, we found missense mutation. They were homozygous for this recurrent mutation, and the third patient is a compound heterozygous, but all these variants of the gene has been demonstrated to be pathogenetic. The second phenotype of NBIA, of PKAN, has been described in 2 siblings, and I have named the congenital phenotype. These 2 patients presented at birth with microcephaly, low weight, they develop a severe psychomotor delay development. They reach autonomous gait around age 2 that is described as ataxic. They have a clinical picture with spasticity, severe cognitive impairment, but there is no movement disorder. There is no visual system involvement. And if we go to the magnetic resonance, it's very different from the previous phenotype, which means that in these two patients, we don't see any iron, nor in pallidum, nor in the substantia nigra, up to the age of 11 years. But instead, they have these striatal lesion hyperintensities associated with the slight white matter changes and a small corpus callosum. These two siblings have the same mutation that we see in the Italian patients, plus another one, and all these have been demonstrated to be pathogenetic. The third phenotype has been described very recently by a group in Netherlands, and is completely different. I have called it the prenatal phenotype, and you see in this patient, actually, in this during pregnancy at 20 weeks of gestational age, it was evident a severe malformation of the brain of the body. So the gestation was terminated, and the autopsy revealed as a major pontocerebellar hypoplasia, severe microcephaly. There is no signs of iron accumulation, so completely different. And screening other cases with a similar phenotype, the authors found another family with 6 children. 3 were affected by the same phenotype. So the first cases was born at term, but again, severe microcephaly, arthrogryposis, and died at the age of 1 month. And the subsequent 2 pregnancies were terminated because, again, it was found by ultrasound the same severe malformation. In these patients, you see they found this mutation, and probably these mutations are more severe than the previous mutation that we see in the previous 2 phenotypes. So we can say that at the end, by reviewing these 9 patients, PKAN is for sure an ultra rare disease. Probably most of the mutations are not compatible with life, but there is a wide clinical spectrum that ranges from NBIA to lethal brain and somatic malformation. And if we want to summarize the major radiological aspects, we can see that iron in the brain plus striatal lesion is highly suggestive for PKAN, but also a clinical radiological picture of pontocerebellar hypoplasia. Thank you very much.
Thank you, Giovanna. Very, very interesting, the phenotypic spectrum for this disorder. We are open for questions. Maybe I can start off with a question. Is there reason to consider, so I believe that the linear pathway of synthesis from pantothenate to CoA is not the whole story. So you might imagine that treating a CoA synthase defect with 4-phosphopantothene doesn't have a rationale, but I wonder if you plan, even maybe in the mouse model, to test this, or in cell studies to test this. Giovanna?
Oh, I think this was for Ivana.
No, it's for you, as the treating doctor.
Let's say that my personal experience is on 2 patients, and so it is really, they really look like PKAN, but really much slower. Actually, it is, I don't know, we are just now going for symptomatic treatment as any other NBIA patients. And actually, we wanted to start to try somehow directly COE, which is the most, the most reasonable approach. Just go directly to the end of the metabolic pathway. And I don't think it makes any sense to try the precursor or even the ferriprone in order to reduce the iron, which again, especially in this form, is really, I would say, just really an epiphenomenon and has nothing to do with the pathogenesis of the disease.
Thank you. Maybe DCA, as was suggested with Odie's talk. Yeah. Okay, we've regained a little bit of time, and so I'm going to actually suggest that we pivot and begin the roundtable discussion. So in order for everyone to attend this current session, you went to the meeting site and you clicked on join session. What you now need to do is...
By Manju, sorry.
Oh, I do see one. Okay, so let me ask the single question for Manju, and then I will pivot the group. Do you think the rarity of this is due to fetal lethality? And what does NOMAD predict with regard to prevalence? So Giovanna, hopefully we haven't lost you. This is a question for you. Do you think the rarity of this is due to fetal lethality?
Yeah, I think so.
Okay.
And also from the very few reports, but the more severe mutation are associated with the prenatal phenotype, which is actually was lethal. Only one case survived 1 month, and there are more complex brain malformations. So I think yes.
Okay.
But also we are looking in the wrong patients for mutations. Yeah. So that's another possibility. So of course, I think within the NBIA is very rare. I think all the major group, I screened the idiopathic NBIA patients for COPA mutation. I didn't find anything. So probably we should look for other. I was interested in the two brothers. We have this congenital microcephaly, severe retardation, ataxia. So maybe we should look for outside the NBIA phenotype.
That's very helpful. Thank you.